Good evening. At the outset, I would like to thank Dr. Mohan Rajan, Dr. Sujata Mohan, Dr. Ravi Shankar for the opportunity. And I'm happy to be part of this Rajan Eye Care Ophthalmic Education series. Thank you, sir. So, the first debate that is DSEC against PDEK. So, I'm talking for DSEC. We all know endothelial transplantation has advanced significantly over the last several years with multiple options now available, including DSEC, DMEC, and PDEK now. One reason that I prefer DSEC procedures is the versatility of the procedure. DSEC actually stands out as the easier technique and is often preferred to PDEK because uh, primary failure is more common with PDEK, and PDEK poses the threat of a significant detachment rate. There are various studies which have been published, and it's available from 2005 onwards on DSEC, where they have studied complications associated with the DSEC and found that the procedure is pretty safe. And if you see the outcome, visual outcome, it's 20/40 or better in almost 70 to 100% of the cases. And other complications like other outcomes like mean spherical equivalent or mean change in astigmatism is not very high. So the mean spherical equivalent is around 0.5 to 1.5 diopters, and mean change in astigmatism is also 0.1 to 0.6 diopters following DSEC. Other complication like graft survival, if you see, it is pretty good. 5-year graft survival is almost 93 to almost 98%. So the graft clarity is maintained even after 5 years in almost 98% of the cases. Other complications like primary graft failure it ranges from 0.3 to 17%. And graft detachment rate is 0 to 25% according to various studies. And rejection is again 0 to 11%. And glaucoma again, it is just 0.3 to 9.5%. So overall, the complication rate is less with the DSEC. And my friend Susan may argue that thinner graft directly leads to lesser amount of donor stroma being transplanted, that theoretically translates into early clearance of stromal tissue. Even with the DSEC, we can prepare thinner grafts. This is a thin graft which I am preparing. I usually inject an air bubble into the artificial anterior chamber. So that acts like a guide so that I will not perforate the posterior, the lenticule. So it is easy. We can even create less than 100 micron grafts with DSEC. So that comes with experience. This is a case, the previous case, you see how thin the graft is. Of course, the handling has to be perfect, otherwise you may damage the endothelium. I usually dye this graft. It's a very thin graft, and I use sheets glide for implantation. I don't use any AC maintainer. It is not required. So in a hypotonic eye, you can use a sheets glide. You can see such a thin graft. It is as thin as a PDEK graft. It may be slightly thicker than that, maybe 50 microns, 60 microns in thickness. You get excellent results. So over a period of time, this clears very well. And the first day post-operative picture will be very nice. This is the 6 weeks post-op. You can see a thin lenticule, which is as thin as the epithelium. It's around 50 microns. It's a very thin graft. It may be like a PDEK graft, and the results are very good. The patient gains 6 with a very small cylindrical power, and it can be done easily. Repeatability is maybe like the challenge for thin DSEC is we still have to come up with the techniques to provide reproducible and accurate thin tissue. But with experience, you can prepare thin grafts. This is again a thin graft, which is less than 100 microns, goes into the antechamber easily. You can make a 3.5 millimeter incision and insert this graft easily. There's no need of any AC maintainer, which is required for a PDEK graft. And handling of these tissues is very easy as compared to the PDEK graft or DMEK. And this is the first day post-operative picture. You can see the thin lenticule is very thin in the first day picture. There is hardly any tissue which is added. It looks as if nothing has been added. So the results are good with the DSEK, and it's much more easier as compared to PDEK. So there is a dislocation which can happen in any of the procedures, but the dislocation rate is less, and the handling of this dislocation is easy actually in case of DSEK, but it is very difficult to handle a dislocated graft in case of PDEK or DMEK. So it's easily, you can manipulate the graft, center it, and inject air bubble and attach it to the inner surface. So FAK cases, you see this may be like a PDEK or a DMEK graft. So the graft can
4 minutes over, Dr.
It can drop into the vitreous cavity. So it's such a thin graft, it can drop into the vitreous cavity. Whereas this particular graft, it is thick, and there's hardly any chance of this graft dropping into the vitreous cavity. So it may be a little difficult to inject air bubble into the antechamber and to form a chamber because air can escape into the vitreous cavity, but it can be done easily. But this is difficult in case of PDEK or in
Wind
case
up, Shreesh, because you have to go to the next.
This last slide, sir. Similar to DMEK, the disadvantages of PDEK are learning curve for preparing the graft and folding and floating the graft. And failure to form type 1 bubble, you may not get a type 1 bubble in all the cases. Graft size is actually, it is a smaller sized graft. You are transplanting less amount of endothelial cells and reverse graft unfolding. And this is their own publication, Susan's publication. I think it's a short series of 12 PDEK eyes. They have noticed 4 eyes with the detachment. That is almost 33%. So their long-term results and incidence of haze rejection is not analyzed. So DSEK surgery is the procedure that can be done for all form of diseases that require endothelial keratoplasty, and that is really the go-to procedure for most surgeons. And my choice is the middle one, that is DSEK, not too thick a graft that like a PK, or not too thin graft like PDEK. So my preferred technique is DSEK with good results. Thank you very much.